Hello and welcome to my Opthal teacher. So we talked about the clinical features of bacterial keratitis and documentation of corneal lesions in the first part of this lecture. So today we'll be dealing with investigations, treatment, and complications of bacterial keratitis. Right. So starting with the investigations, the first investigation is a corneal scraping. Right. Now we use non-preserved topical anesthetics for this purpose because the preservatives in these anesthetics, they are bacteriostatic in nature. So preferably non-preserved topical anesthetic is instilled. That is the first step. Remove any loose mucus and necrotic tissue before scraping. Now, how is the scraping performed? It can be done with the help of a disposable 11 number blade, bent tip of a 20 or 21 gauge needle, or a Kimura spatula. What is to be scraped? The edges and the floor of the ulcer have to be scraped. Okay, as you can see in the picture, in the first picture. Also, if you need to do a repeated scraping, for example, when you have to plate it on different media, you should have a different pass over the ulcer each time. And in between the scrapings, you must sterilize the instrument. If using the same instrument, you have to flame sterilize it or use a fresh scalpel blade or needle for each pass. Sometimes calcium alginate swabs, which are commercially available, may be useful. Now, why calcium alginate swabs? Because it has been noted that cotton swabs or synthetic swabs are also bacteriostatic or bactericidal in nature. Unlike calcium, in fact, even calcium alginate swabs are bacteriostatic, but they are the best available. So they can be used in order to inoculate the first scraped specimen and transport it to the laboratory. So this picture is that of blood agar, and it is showing the golden colonies of Staphylococcus aureus. So ideally, the culture plates should be readily available. You scrape, you put it on a slide for staining, and at the same time, you inoculate the culture media. So that is important for you. What to use for scraping? Remember to flame sterilize the instrument if reusing, or remember to use a fresh scalpel. Next, a thin smear is placed on labeled glass slides for microscopy. I already told you that. You scrape it and you take two glass slides, label the upside of the glass slide, two different slides, one for gram stain and one for KOH. Ideally, both these tests should be done as soon as possible, and you avoid the drying up of the slide. If it needs to be transported, then you dry at room temperature, place in a slide carrier, and then transport to the laboratory. Remember, this facility is not available everywhere. Of course, you have to rescrape for each culture media or plate. And remember that when you are inoculating each of the culture media, you should not break the gel. The surface of the gel should not be broken, it should remain intact. You inoculate in a C shape, right? So these are the most common culture media used. This one is nutrient agar, blood agar, and chocolate agar. So this one is a growth on chocolate agar. Chocolate agar is specific for Neisseria. Now, if you're using refrigerated media, often these plates are brought in a refrigerated medium, so you have to gently warm them to room temperature before you plate the organism, else the organism dies because it is sensitive to temperature. If these plates are not available, you can use a single scraping and put it in BHI, which is a liquid medium, brain heart infusion broth. It is a broth. So a single scrape is just placed into the broth, which is then transported to the laboratory. It is homogenized and then it is plated on different culture media plates. This is when the culture media plates are not available. Now, whether or not you should delay treatment uh, is a decision which varies from doctor to doctor. If suppose the patient has already been on antibiotics before he or she comes to you, then obviously the culture is going to be sterile. In these cases, it may be possible to delay the treatment for a period of 12 hours, then take the sample for culture, and then restart your empirical antibiotics. But then this is decided on a doctor to doctor basis. But remember, if the treatment needs to be stopped, there is a waiting period of 12 hours until the antibiotics have been eliminated from the ocular surface. At that moment, after the 12 hours, you take the culture again and then restart the antibiotics as you await the results. Now that's important. Thin smear, 2 glass slides at least for gram stain and KOH stain. There are a number of other stains, but then these are the basic ones for which you have to send the sample immediately. So culture and sensitivity reports should be obtained as soon as possible. Sometimes when the scraping is negative, you can use conjunctival swabs. And as discussed, calcium alginate is the least bacteriostatic. If the patient is a contact lens user, suppose you have a patient with a pseudomonas infection, probably because of contact lens use, it is necessary that you send the lens itself along with its case and solution bottle to the laboratory for culture. Now look at the two tables. The first table here, this is actually showing you the culture media for different organisms. So most bacteria and fungi except Neisseria, Haemophilus and Moraxella can be grown on blood agar. Fastidious bacteria, which are demanding bacteria, they need specialized conditions to grow. They include H. influenzae, Neisseria, and Moraxella. The ones that do not grow on blood agar will grow on chocolate agar. Then Sabro-dextrose agar is for fungi. Then there are a number of other media. See, the brain heart infusion broth is mentioned over here, right? LJ medium is for mycobacteria, nocardia. Cooked meat is for anaerobes. At least try to remember the first three. These are the basic culture media in which the scraping is sent first. Now look at the stains. So for you, Gram and Gienza stain, and I'm sorry that KOH is not mentioned here. 10% KOH is a must. So Gram stain, KOH stain, in fact KOH mount. It is not a stain exactly, it is a mount. 10% KOH mount and Giemsa are the basic initial stains. Important to remember the differential diagnosis. Now, you can say that other infective keratitis, there are a number of other causes. So, apart from bacteria, you can have fungi, you can have acanthamoeba, mycobacteria, and even stromal herpes simplex keratitis can resemble bacterial keratitis. Besides this, you should remember some non-infective causes such as marginal keratitis, sterile corneal infiltrates from contact lens wear, peripheral ulcerative keratitis, and toxic keratitis. So, fungal keratitis, this is different from a bacterial keratitis. Look at the typical feathery margins and the little satellite lesions that are there. Then you can have necrotizing stromal herpes simplex keratitis. So, even a viral infection can look like this if there is severe stromal involvement and accompanying scleritis. And look at this. This is a toxic keratitis caused by ciprofloxacin deposits on the cornea. So these are just some of the differentials of bacterial keratitis. Please remember the non-infective keratitis also exists. Treatment consists of some general considerations. So what are these general considerations? The first two are very, very important. Hospital admission for patients who are not likely to comply, who are coming from far away, who are unable to self-administer treatment, such as paralyzed patients, patients with aggressive disease, and patients who are one-eyed. Discontinue contact lens use immediately. Then besides this, some other considerations which may be followed: clear plastic eye shield between eye drop installation if there is a lot of thinning or impending perforation of the cornea. Intensive treatment may not be needed for small infiltrates. Empirical broad spectrum treatment is initiated before the results are available. So these are general principles. So, general considerations taken into account. What is the mainstay of treatment? Local therapy. In local therapy, the mainstay of treatment is antibiotics and mydriatics/cycloplegics. They are invariably used in almost all cases of keratitis. Besides these, we have systemic antibiotics. Also, we should manage apparent treatment failure. We should know how to manage perforation and how to visually rehabilitate the patient. We'll be discussing the last 3 points in the end. Let us focus on the antibiotics used for treatment of bacterial keratitis. So topical therapy or eye drops, they achieve high tissue concentration. You need the high concentration of the antibiotics on the cornea and in the anterior chamber. So eye drops are the way to go. Start with broad spectrum antibiotics at hourly intervals, both day and night, for a period of at least 24 to 48 hours. This is after you have taken the scraping and sent it for culture and sensitivity. Antibiotics can be used as a monotherapy, that is a single drug. The advantages of monotherapy being lower surface toxicity. Remember, antibiotic drops also have surface toxicity. I showed you the ciprofloxacin deposits on the cornea in the previous slides. So lower surface toxicity if you use a single antibiotic, obviously. Plus, they are convenient. Just one drop is to be instilled as compared to duotherapy. Dual therapy means you use a combination of one or more antibiotics. Now remember, resistance to fluoroquinolones, which were once very widely used, very successful antibiotics for corneal ulcers. Resistance to them is rising. For example, Pseudomonas has been shown to be resistant to fluoroquinolones in a few Indian studies. Moxifloxacin, gatifloxacin, and becifloxacin, these are the newer generation fluoroquinolones and they are effective against gram-positive organisms. Remember, moxifloxacin has the best ocular penetration. And of course, we are still using moxifloxacin as a broad-spectrum antibiotic almost everywhere. Ciprofloxacin, we know, causes corneal precipitates. So look at some of the antibiotics, right? So empirical treatment preferably is done using moxifloxacin or some other newer generation fluoroquinolone as a monotherapy or as a duotherapy. Gram-positive cocci are susceptible to the following antibiotics. Similarly, gram-negative susceptible to gentamicin, fluoroquinolones or ceftazidime. Gram-negative cocci susceptible to again fluoroquinolones or ceftriaxone, mycobacteria and nocardia with their respective antibiotic to which they are susceptible. Remember, empirical therapy. You can either use fluoroquinolone monotherapy or a combination duotherapy for empirical treatment depending on the type of the ulcer it is. So this is what this slide is about. It is about empirical treatment in the form of monotherapy or duotherapy. Now, duotherapy is usually given in aggressive disease. It involves a combination of two or more fortified antibiotics. Now, fortification. Remember, what is fortification? Fortification means that a standard parenteral or lyophilized antibiotic preparation is combined with a compatible vehicle such as non-preserved artificial tears, such that the antibiotic does not precipitate. So the advantage is that it contains a fortified antibiotic would contain a higher concentration of the antibiotic per unit volume when you compare it to eye drops. That is what you mean by fortification of antibiotics. Just like we have foods fortified with vitamins, we have fortified antibiotics. These should ideally be prepared under sterile conditions. The problems with fortification of antibiotics is that they are costly. Of course, parenteral antibiotics are costly. They have limited availability. They have a risk of contamination because, after all, you are going to manually prepare it. They have a short shelf life. They need to be, made again and again after a shelf life of 4 to 5 days. And they need refrigeration. They cannot be kept at room temperature. Preparation of fortified antibiotics. Now, in this table, I've shown you only the basic ones. Since we commonly use a preparation of fortified ceftriaxone for gram-positive coverage plus gentamicin for gram-negative coverage, I have only discussed the method of preparation of these antibiotics, these fortified antibiotics over here. This is the concentration. Please, you must remember at least the concentration of these cephalosporins and gentamicin, and this is the shelf life. You cannot forget this table. Besides these, you also should remember fortified vancomycin because there are a lot of methicillin-resistant Staphylococcus aureus causing a number of infections these days. So vancomycin is another broad-spectrum antibiotic which kills most gram-positive organisms, some gram-negative and anaerobes as well. Please refer to this particular journal. There was an article published in which they have a detailed method of preparation of almost all the fortified antibiotics, be it antibacterial, antifungal, anti-acanthamoeba, anti-tubercular. So you can refer to this article. It's a very, very useful article for you. But try to remember at least how to prepare fortified ceftriaxones, fortified cephalosporins, fortified vancomycin, which is not mentioned here, and fortified gentamicin. That is the bare minimum that you should remember for your exams. Moving on, mydriatics or cycloplegics are another, pillar, the second pillar of the armamentarium of treatment of bacterial keratitis or any keratitis for that matter. So antibiotics, then mydriatics, cycloplegics. Why are they important? Because they prevent the formation of posterior synechia and reduce pain. Now, in cases of, may say, viral keratitis, antibiotics, topical antibiotics may not be useful unless there is a super added bacterial infection. But cycloplegics have to be used. So mydriatic cycloplegic is one drug that is used in almost all cases of keratitis, irrespective of the antibiotics, to prevent the formation of synechia and to reduce the pain that is associated with ciliary spasm. Please remember, very, very important. Now, steroids. Steroids are not a part of the mainstay of the treatment. Please listen very carefully. Steroids, they may be useful in cases of corneal scarring and to avoid corneal graft rejection. Remember, non-tubercular mycobacteria are the most important causative organisms in case of ulcers involving corneal grafts. We've already discussed that. So, in such special conditions, steroids may be used. What do they do? Of course, they reduce inflammation and improve patient comfort. But they are absolutely contraindicated in fungi, viral infections, and mycobacteria. So, where did this idea of steroids come from? They came from a trial known as the steroids for corneal ulcer or the SCUT trial. Now, they saw that in cases of severe corneal ulcers, such as a large, say more than 4 diameter, central corneal ulcer in the pupillary area, or if the patient's vision is hand movement or something, that comes under the category of severe corneal ulcers. Such cases respond to corticosteroids in terms of the final visual acuity. So corticosteroids, topical steroids were started in these cases once the ulcers had healed, very important, with the help of antibiotics. Then the steroids were given, and since steroids minimize scarring, the final visual acuity in these cases may have been significantly better as compared to controls. Remember, steroids have to be started only after antibiotics, typically 24 to 48 hours later, and very, very low concentration, low potency steroids in, uh, you know, longer frequencies, such as, say, 2 to 4 times daily and not hourly, may be given under supervised conditions. Please do not say steroids are the mainstay of treatment of corneal ulcer or any keratitis for that matter. You should not utter the word steroids as the first thing in the treatment of corneal ulcers. The first thing is antibiotics plus cycloplegics, followed by systemic antibiotics. Now, systemic antibiotics, certain systemic infections may respond to better to systemic antibiotics. Plus, their systemic manifestations can also be controlled. For example, in Neisseria meningitis, you can use benzyl penicillin, IM benzyl penicillin. In Haemophilus, we give amoxiclav. In gonorrhea, we give IM or IV ceftriaxone. In cases of severe corneal thinning with threatened or actual perforation, we give a fluoroquinolone for the infection and a tetracycline for its anticollagenase effect and preventing perforation. And of course, scleral involvement. So these systemic infections and these last two conditions, these are some of the indications of systemic antibiotics. So topical antibiotics, cycloplegia, systemic antibiotics if needed. Rarely subconjunctival antibiotics can be injected. Do not mention steroids unless asked. And if you're writing answers, you can mention the SCUT trial and say that steroids can be given to prevent corneal scarring only after the ulcers have healed. Now, what happens if there is apparent treatment failure? First of all, what is apparent treatment failure? No improvement following 24 to 48 hours of intensive treatment. Intensive treatment means you're putting the eye drops hourly, day and night. No improvement in 24 to 48 hours. What do? You review the antibiotics, change the antibiotic. If you want, you can even revise the microbiology, redo the scraping and the plating, and send to the lab for a revision. Still no improvement after a further 48 hours. What do? You suspend treatment for 24 hours. Now, sometimes because of this multi-drug use, uh, you can have an apparent treatment failure of the corneal when you're treating a corneal ulcer. So what you do is, because these drugs themselves are toxic to the cornea, so what you do is you suspend the treatment for 24 hours, allow the cornea to heal, then you rescrape and send it for some additional cultures and additional staining techniques. There were a few staining techniques that we did not discuss, such as calcofluor white and histidine orange. These are some additional stains which you can request the laboratory personnel to do. Additional cultures, for example, brain heart infusion broth or something else, can be used if you are suspecting a non-bacterial cause such as acanthamoeba or fungus. If cultures still remain negative, you may need to do a corneal biopsy for histopathology and culture. Now, coming on to the general complications, that was about the treatment. So, we talked about topical antibiotics, which includes monotherapy and dual therapy, systemic antibiotics, cycloplegics, and plus minus steroids. Now, coming on to the general complications of corneal ulcers, if an ulcer is allowed to progress through its course, what happens? Untreated. If the ulcer is deep, there is a loss of enough stromal tissue such that the cornea thins out at the site of the ulcer, and the whole structure bulges because the eye has its own intraocular pressure. So the remaining corneal tissue bulges out, Sometimes the tissue may consolidate because there is a healing also going on, there is fibrosis going on, but the bulging will remain permanently, and this is referred to as an ectatic cicatrix. That is the thinned out, bulging corneal tissue following healing of ulcer. I have highlighted the complications in yellow, so please note in the subsequent slides as well. So that is your ectatic cicatrix. Sometimes certain ulcers extend very rapidly in depth and involve the entire thickness of the cornea until they reach the descemet membrane. Now, the descemet membrane is resistant to inflammation, but it cannot support the IOP by itself, and it is highly elastic. So, it herniates through the ulcer as a transparent membrane called descemetocele. You see, look at the slit, look at the thinning. Most of the stromal tissue is lost, but the descemet is resistant to perforation. However, it is not strong enough to support the IOP, so it herniates out. Hence, the name descemetocele is given. Now, this descemetocele may persist. Eventually, a descemetocele can still rupture, leading to perforation of the corneal ulcer. What happens in perforation? Now, perforation is usually caused by a force such as coughing, sneezing, straining. So, ask about history of such an episode from your patient. These, maneuvers like coughing, sneezing, they cause a rise in intraocular pressure. With further rise in the intraocular pressure, the corneal tissue, which is already weakened by the infection, gives way. The floor of the ulcer gives way and the aqueous escapes out suddenly. Please keep this diagram in mind. The aqueous escapes and intraocular pressure falls to the atmospheric level now that there is a communication between the aqueous and the atmosphere. With this, iris and lens are also driven forwards. As the aqueous is flowing, the iris and lens are also driven out towards the exterior. Now, as this happens, the intraocular pressure falls, the nutrition of the cornea is improved because the intraocular pressure has fallen and there is improved fluid exchange. So now the patient's symptoms are alleviated. His or her pain subsides and the destruction of the further destruction of the stromal tissue stops and healing begins. But with healing also comes scarring, and scarring comes with its own dangers. So if the perforation is small, the iris is gummed to the opening. As you can see here, it is gummed to the opening, it adheres over there, and the scar tissue over it gets organized, and this leads to the formation of anterior synechia. Anterior synechia means an adhesion between the anterior surface of the iris and the corneal endothelium. That's what you mean by anterior synechia. A posterior synechia is between the anterior surface of the lens and the posterior surface of the iris, seen in uveitis. Anyway, so this is your anterior synechia, and the part of the cornea that is exposed to the surface, this is known as pseudocornea. I'm sorry, the part of the iris that is exposed, the corneal tissue is lost. The part of the iris that is exposed, it is covered by scar tissue and it is known as a pseudocornea. Once this has happened, the anterior chamber starts reforming. Now that the perforation is plugged, the anterior chamber starts reforming, right? So that's that. Now, suppose the perforation is large. A majority of the iris is carried into it, in fact, and this would cause an iris prolapse, as you can see here. If the perforation is very large, the entire corneal tissue may even slough out. Only a rim of the corneal tissue would remain, and once this sloughs out and a tissue loss occurs, what happens to make up for that tissue loss? The whole iris, almost whole of the iris, prolapses through the perforation, and that is what you call an iris prolapse. After iris prolapse, scarring begins. With the scarring, there is contraction of the fibrous tissue, and the prolapsing iris is flattened out. However, This cicatricial tissue, fibrotic tissue, is too weak to support the restored IOP. And now that the anterior chamber has reformed, the IOP would gradually rise, but the intraocular tissues would be unable to support it. This would lead to secondary glaucoma, another complication, right? Then we talked about ectatic psychiatrics. So ectatic psychiatrics is in which ectatic psychiatrics simply means thinned out corneal tissue which is protruding, right? That was the first complication that we discussed. Sometimes the iris gets incarcerated in that thinned out corneal tissue, and then the structure that results is known as an anterior staphyloma, as you see here. Now, if the perforation happens opposite the pupil, I already told you this in the previous slide, the pupillary margin of the iris adheres to the edges. The whole pupillary aperture is filled with exudate, and in these cases, anterior chamber is formed very, very slowly. The whole of the iris prolapses. What happens to the lens? Behind the iris is the lens. Now, this lens would remain in prolonged contact with the ulcer, and in such cases its nutrition is impaired, leading to the formation of an anterior capsular cataract. It is a type of complicated cataract. Some more complications. Once the anterior chamber reforms, exudate filling the opening is strain. It is under constant strain, and it ruptures repeatedly. Sometimes there is a reformation of the anterior chamber, but then the structure that is plugging the perforation, which is composed of exudate and scar tissue, it cannot bear the intraocular pressure, right? The intraocular pressure is slowly rising. These structures cannot bear it. As a result, a reperforation happens, and sometimes this repeated cycle of events would lead to the formation of a corneal fistula. Sometimes this is when the perforation is a slower process. If the perforation is sudden, the suspensory ligament of the lens may be ruptured, and a sudden decompression would lead to subluxation of the lens or even its anterior dislocation, along with spontaneous expulsion of the vitreous and the lens through the opening that has formed over there, the perforation. And this is what it looks like. So, a sudden perforation can lead to spontaneous expulsion of the lens, the iris tissue, and the vitreous. And this may be accompanied by a phenomenon known as expulsive hemorrhage. Now, where is the hemorrhage coming from? You see, in cases of sudden perforation and sudden reduction of IOP, the intraocular vessels dilate. And when they dilate suddenly, they may even rupture, leading to intraocular hemorrhage. This in turn can cause vitreous hemorrhage or choroidal hemorrhage, and the contents of the globe can extrude along with the outflowing blood, and then it is known as expulsive hemorrhage. Lastly, the infection may gain access into the interior of the eye once a perforation has happened and a communication exists. These agents, these infections, these microorganisms go inside and cause endophthalmitis or panophthalmitis, leading ultimately to blindness. So, how do you manage the complications? Say there is a perforation, a small perforation somewhere in the corneal periphery can be managed by a bandage contact lens. So this is what the bandage contact lens, it's a transparent soft contact lens that sits on the top of the cornea and acts like a bandage and helps to prevent perforation. Tissue glue. See, this is an example of a tissue glue. There is a small perforation where the tissue glue has been applied. Now, tissue glue can either be cyanoacrylate or fibrin glue. So this also helps prevent an impending perforation. And if the perforation is large, you may need a penetrating keratoplasty or a corneal patch graft. How to manage endophthalmitis? The approach is similar to that of postoperative endophthalmitis. Visual rehabilitation. This we're talking about once the scarring has happened. So depending on the level of the scar, you can do a partial thickness or a lamellar keratoplasty for residual dense scarring. This is a picture of a penetrating keratoplasty actually. Then scars can produce irregular astigmatism, which can be treated with rigid contact lenses. But you have to wait for a period of 3 months after the reepithelialization, after the healing, before you apply any kind of contact lenses. And cataract surgery, of course, if there is a complicated cataract. So that is about the management of the complications. And thank you for listening. And you will have the lecture uploaded on my YouTube channel. You can always go back and revise. And I really hope this helped in clearing a lot of your concepts. Please refer to Parson and Kanski as your standard books for, having a basic knowledge of these diseases. Thank you again.